Hello, everyone. Thank you for being here and happy International Women in Statistics and Data Science Day. Um, my name is Marissa Ashner, and I'm a biostatistician and graduate instructor at Duke University. And today I'll be the chair of this session, which is titled Innovations in Precision Medicine and Optimal Treatment Strategies. So we'll have three wonderful early career researchers that will talk about their work in this field. And they will have about 15 minutes each to present and then a few minutes for a Q&A as well. And so I will introduce them as they present. And so the first one, we will have Christina Zhou up first. And Christina is a doctoral candidate in the Department of Biostatistics at UNC Chapel Hill. She's a member of the FAIR Lab, working under the advisement of Dr. Michael Kosarak. Her research focuses on developing precision medicine methods for survival data to estimate optimal treatment regimes. And in today's talk, she'll present her research for novel precision medicine methodology for survival data with competing risks. So I will hand it over to Christina.
Thank you for that introduction, Marissa. I'm currently sharing my screen. Let me know if you can't see it in full screen mode. Yes, today's talk will be on optimal individualized treatment regimes for survival data with competing risks. So a very brief background on precision medicine. As mentioned in the intro, a lot of this work is done in the Precision Health and Artificial Intelligence Research Lab at UNC, but we are trying to find ways to tailor medical treatments to individual characteristics. So essentially the idea of finding the right treatment for the right patient at the right time. So one key focus of this is estimating the individualized treatment regimes, or ITRs, which are data-driven, formalized data-driven approaches that map from the covariate space into the treatment space. So the problem area that motivates our research for today's talk is peripheral artery disease, PAD. And this is a condition that narrows the arteries in the limbs, and which can lead to severe consequences. And oftentimes, patients with very severe levels of PAD require surgical intervention. And so, unfortunately, even after this happens, there's still that risk of losing their limb, or unfortunately, they may even die. And so peripheral artery disease is a serious condition. And even though there's multiple treatment options, currently there's not really a clear answer as to which one is best for the patient. And so then one motivating thing for our research is to find the optimal individualized treatment regime. And so currently there are a lot of existing approaches for precision medicine for survival data, but currently they mostly focus on one endpoint. So specifically, one very common thing is looking at the survival function, looking at the probability that you had survived up to a time point t, given that you didn't refail. But oftentimes there's multiple endpoints that we want to consider. And this is more crucial in being able to see the general picture of the full picture of the patient's information. And so in this case, what if we do want to consider multiple endpoints? So for example, in competing risks where there are multiple mutually exclusive events that can occur and the occurrence of one precludes the occurrence of the others, we oftentimes here look at the risk of that one event, so cause specific. So in this case, examples can include death from multiple causes. For example, death from heart attack versus death from like cancer. And so often in these cases, you can't just ignore or lump them together. It gives you more of a holistic view to look at a cause specific. And so in our peripheral artery disease example, the two competing risks would be dying versus amputation before death. And so in our specific research setting, we are looking at multiple causes, but we assume there's one cause of interest that is particularly more crucial to consider. And so in our motivating example, in this case, we would be more concerned about death instead of amputation, even though we do definitely care about both. So to introduce some brief notation, we have the standard survival notation here. So we're letting epsilon be the cause. And so this is indexed by J. So if there are J causes, we are particularly interested in the main one of interest, which would be cause 1, and then all the other ones can be looped into a generic cause 2. And so we're also looking at failure time T. And so now we have multiple causes of failure time, but T is just the minimum of all of them. And we call this overall failure time. And so then we have our observed time, which is the minimum between that failure time and censoring, since we're working with survival data. And then we have our event indicators and then our cause-specific event indicator. And so we're going to call this main cause of interest a priority cause. And so then our observed data is our covariate Z. And then we have our observed time as well as our status indicators. And then we're letting tau denote end of study. So we're going to let A denote our treatment space. And so we assume a finite treatment space. And then we have our survival function as well as cumulative incidence function. And then our ITR, which again is mapping from the covariate space to a treatment space. And so our framework is particularly looking at, rather than modeling the survival probability or cumulative incidence probability directly, we're actually looking at a criterion. And so in this example for this presentation, we're going to look at the truncated mean, which is essentially the mean restricted survival time at time tau, which is the end of study. And so we're operating in a potential outcomes framework here. And so we're saying that for this treatment A, if someone were to receive treatment little a, then we have our truncated mean for survival time and truncated mean for cumulative incidence for our priority cause J. And so then since we're looking at 2 different endpoints here, we're introducing a multi-utility framework. So we want to look at both this phi1 and this phi2, where 1 refers to the survival endpoint and then 2 refers to the cumulative incidence. And so then in this case, what we would like to estimate is that our framework is essentially prioritizing survival first. And so we're looking at the treatment that maximizes over all the treatments your truncated mean survival time. And so then if you do that and then you plug into your truncated mean, you get the corresponding optimized truncated mean survival time if someone were to follow that maximum one. And so we also want to introduce a tolerance here. So I mentioned that we are particularly interested in overall survival, maximizing that, while later looking at minimizing the cumulative incidence for the priority cause. And so in order to determine which one we're looking at, we need to introduce this tolerance alpha. So if 2 treatments are giving very similar survival times and they're within a tolerance, then we're saying, okay, although we're prioritizing that, we also want to consider the other endpoint. So in this case, we're really trying to find this optimal ITR, which would be the minimum of the cumulative incidence of the priority cause if it's within that alpha tolerance range. And then if it's not, then we want to choose the treatment that maximizes survival. And so then our corresponding value function is technically given here in technical terms. And this is basically what the expected criterion would be for a population if they were to follow the treatment regime. And so in order to estimate our survival curves, we're using force-based methods. And so in 2023, Cho et al. introduced the generalized random survival forest, which outputted individualized survival curves. And so we essentially did a single stage adaptation of this since they were focusing in multi-stage treatment settings. So in our forest, we have multiple trees where the number of trees is a hyperparameter. And within each tree, we're splitting the nodes based on covariates. So we're sorting the covariates and getting basically each different split point. And so then we're testing using the estimating the survival curve using Kaplan-Meier, and then testing using a mean difference test, which allows us to essentially compare the truncated mean times within each node. And then if they're significant, then we split. And if not, then we stop. And we essentially continue this until the node size is smaller than 2 times our minimum terminal node size, which is another hyperparameter required. And so this in the end will output individualized prediction curves for overall survival. And this is how we get our S hats. And so similarly for the cumulative incidence function for a priority cause, we also we developed random cumulative incidence forests, which have the input parameters of number of trees as well as minimum terminal node size, similar to the random survival forest. But this time, when we're partitioning the covariate space, we're using the Allen-Johansson estimator to estimate cumulative incidence function. And that's very similar to a Nelson-Allen, but it's adapted to look at the cause-specific events. And then we partition this feature space using the Gray's test, which is an extension of the log rank test. And we again do this until the node size is less than 2 times the minimum. And then from there, we can obtain the terminal node estimators and then average across to get the forest estimator. So putting this all together, we proposed this two-phase estimation procedure, where the first stage is looking at the overall survival, and the second stage is looking at cumulative incidence. And so using the proposed random survival forest estimator, we can obtain our S hats. And this is after we assume, after we've de-identified the data using assumptions from SETVA, strong ignorability, and positivity. And so now we can also use our cumulative incidence forest to obtain our F hats. And so from here, what we want to essentially do is we want to identify the optimal treatments in this first phase. So for example, if this is a curve for one person as a toy example, we have this blue color being treatment A and this purple color being treatment B. And so this truncated mean time, we can essentially take the area under the curve here. And so treatment A is giving 3.3 years and treatment B is giving 3.1. So normally a estimation procedure would recommend treatment A, but what we're saying is that if this is within that tolerance alpha phi, then we can actually look at phase 2. And if it's not, then we want to stick with phase 1. And so then this phi is the pre-specified phi. And so let's say in this toy example, the pre-specified phi was 10%. And then we can say that since this treatment situation these treatments are within 6%, within 10%, we actually want to go to phase 2. And so then in phase 2, we're saying, okay, although we prioritized overall survival, we want to minimize the priority cause cumulative incidence. And so in that case, if we look at their individualized cumulative incidence curves, we can see that actually treatment B has a cumulative incidence time of 3 years, and so in this case, we would actually recommend treatment B for this patient. And so this is, in technical terms, our estimator for the optimal ITR. And we are proposing this estimator. And under certain regularity conditions and mild typical assumptions, we also proved uniform consisting over time and covariates for first our proposed ITR estimator here, and then secondly, our proposed random survival forest, and then our proposed random cumulative incidence forest. And so for the ITR estimator, this is essentially saying that for a future population of patients with the same data, our proposed estimator will converge to the true optimal estimator as the sample size increases. And so we performed some simulation studies, and we looked at 2 settings, but for this presentation, I'll mostly focus on setting 2, which is looking at dependent failure time. So this is based off fine and gray settings. And so here in our situation, we looked at 2 treatments, 2 different treatment assignment mechanism, one dependent on covariates, one not dependent, censoring, low and high censoring, 2 different training sizes, 300 versus 700, different covariate dimensions. We evaluated on 1,000 evaluation set. And then again, we're looking at this phi of truncated mean. And we also specified our minimum node size to be 5, minimum number of events to be 2. And then we specified a tolerance level of 7%. So our method we call ITR-serve. We compared this to the Cho et al. With the generalized random survival forest, which only looked at maximizing survival, called DTR-serve, and then also 2 competing risk methods from 2021. And these looked at minimizing the cumulative incidence function. We also compared to the zero order model, which is our two-phase estimation approach, but we, instead of assigning 1 treatment per person based on their data, we assigned the best 1 treatment for everyone based on what was best for everyone, as well as your observed policy. And I also want to note that although in this setting, we're only looking at 2 treatments and we only looked at 2 causes, our method can actually accommodate more than 2 treatments and more than 2 causes, which is nice. And so in our simulation studies, this looks like a lot, but I'll break it down in a second. On the left side is our truncated mean overall survival. And then on the right side is the truncated mean cause 1, which is our priority cause, cumulative incidence. And so each panel, each little block is 1 setting. And we have the first method being, the first method is our method, and then the overall survival, and then the 2 competing risks, zero order, and the cumulative incidence. So for the sake of time, I'm just going to go down to this. So generally, all of them kind of narrow down to this, but because of the scaling, we can actually see that our method performs pretty well because we have similar overall survival, where each dot represents 1 simulation, and the black dot is the average across simulations. So we actually have very similar survival while minimizing the cumulative incidence. So that's essentially what we would like to see. And so it performs pretty well here. And so we also analyzed our, compared our method in a real data set, which is our motivating data set to peripheral artery disease patient data set, which had like 303 patients. There were 2 treatment groups, and the disparity is due to the fact that since there's no clear treatment right now, a lot of times it's just based on surgeon preference. So there are a lot of times they're just choosing the endovascular group because that's less invasive than open bypass. So our priority cause is death. So although we want to prioritize maximizing survival from any cause, we would rather minimize the risk of death compared to the risk of amputation if any of those were to happen. We looked at the study for 1 year and then did 10-fold cross-validation. And so we tailored for 29 variables, which were mostly comorbidities, lifestyle variables, and this is what we included in our forest. And so here are the results for our method. And we can again see the left side is truncated mean survival time. And then the right side is actually truncated mean death time in days. So we actually survival. So we actually want the maximum on both sides. And we can see that on average, our method still performs pretty well. It's all pretty similar for survival, but then compared to cumulative incidence, the zero order model performs slightly better, which indicates that our 2-phase proposed method works well, but maybe there's only 1 treatment that's actually better for all of them. So that since they're picking all of them, that's what's happening. And we're performing very similarly to the observed policy, which indicates that our method is performing similar to what the experts, the doctors, are suggesting. And so that's also showing that we're on par with the people of the medical field know, which is pretty good. And so in general, in conclusion, we proposed a novel multi-optimization procedure to estimate the optimal ITRs for the competing risk survival settings. And so our method is accounts for covariates, which is crucial for ITRs. And it's also applicable to more than 2 treatment options, which is really beneficial in a lot of settings where sometimes it's not just binary treatment, even though that's what currently most methods do. And because we're non-parametric, we're flexible and able to capture complex data patterns. And our package is our package, and so it's computationally efficient and very easy to implement. There are current extensions, so we could extend to other criterions of interest, not necessarily just a truncated mean, as well as introducing a tiebreaker. So what if both phases end up with the same multiple treatments with the same criterion? So then how would we tiebreak that? And then lastly, extending to multi-stage diseases, since we're all promoting in the single stage setting. And so that concludes my talk. Thank you very much.
Thanks so much, Christina. That was great. In the interest of time, we'll move on to our next speaker. But if you have any questions for Christina, feel free to share them in the Q&A, and we can probably answer them there. By we, I mean Christina. So now we'll move on to our next presenter, which is Dr. Daiqi Gao. And Dr. Gao is a postdoctoral fellow in the Department of Statistics at Harvard University, working with Professor Susan Murphy. She received her PhD from the Department of Statistics and Operations Research at UNC Chapel Hill, and her primary research interests are in statistical reinforcement learning and machine learning with applications in mobile health and personalized medicine. So I'll pass it over to her for her talk.
Thanks so much for the introduction. Let me share my screen. Can you see it moving? Just to make sure.
Yes, we can.
Okay, thanks. Hello, everyone. Today I'm going to present sequential decision-making with sparsely observed rewards. This work is motivated by our new implementation of a mobile health clinical trial. And this is a joint work with my wonderful collaborators. Xinyu is a former postdoc in our lab. She's currently in Allen Institute. And Paja is a professor in the University of Michigan, and also my postdoc advisor, Susan. So cardiovascular disease is a severe disease that is affecting 10% of the US population. However, the majority of the cardiovascular disease can be attributed to low levels of health promoting behaviors like physical activity, heart healthy diets, blood pressure control, etc. Cardiac rehabilitation program is an outpatient program. We have a team of experts, including like doctors, nurses, trainers, to help a patient who just go through the cardiac events to form a healthy and balanced lifestyle. It has been shown that the cardiac rehabilitation program is efficient at reducing the behavioral risks for cardiovascular disease and cardiovascular mortality. However, after the program ends, the outside support disappears, and this is when the patients go back to the obligations and pressures in everyday life. The heart-healthy lifestyle generally decline in 6 months, and the benefits for cardiovascular health decline in about 1.5 years. This is when we hope the mobile health could provide ongoing support for patients in their everyday life. It has been shown that mobile health is effective at supporting a range of heart health behaviors. But in this work, we will focus on the exercise. We aim to use mobile health to help patients increase and maintain the physical activity in their everyday life. Heart Steps is a mobile health intervention designed to achieve that goals. It contains several intervention components. One of them is about encouraging users to engage in short bouts of physical activity. For example, it might ask user to go for a 10-minute walk, and such message are tailored to the current context. There are 5 potential times a day for sending notifications, and our goal is to find the best strategy to decide when we should send such notifications. A straightforward way might be to use an existing dataset to learn such strategy. However, the heterogeneity among users is enormous. So the best strategy for each user is different. And it's hard for us to know what is the best strategy for this person until we see the data of this person. So that's why we propose to use reinforcement learning to sequentially update the intervention strategy for each user when we have accumulated data of this specific user. Our goal is to maximize the effectiveness of the intervention while minimize user burden. So in hard steps, based on the context, for example, like the current weather and temperature, the RL algorithm will decide whether a notification should be sent or not. And if a user receives a notification, they may or may not be responsive to it. And this responsiveness is reflected in the step count after this intervention. So such information will go back to the RL algorithm, and we can update the intervention strategy. So in the previous implementations of hard steps, our goal is to, the reward in the RL algorithm is just the proximal outcome, the 30-minute step count after the notification. However, a key delayed effect, which is disengagement, is ignored in the previous interventions. This disengagement is a major issue that hinders the effectiveness of intervention in mobile health. So in this new implementation, we aim to directly target this delayed effect and the long-term benefit of the interventions. So in this new implementation, we know that our ultimate goal is to improve the distal outcome, which is the long-term behavior change. However, this signal is too sparse for us to update the intervention strategy. Therefore, in the algorithm, we use the intermediate outcome, commitment to physical activity, as the reward. Such commitment to physical activity is a strong predictor and a mediator of the long-term behavior change. And since the intervention is designed to improve the proximal outcome is actually a mediator of the commitment to physical activity. The commitment to physical activity can be collected through surveys. For example, a survey might ask whether a user tried to get better at doing physical activity, or if the user stopped doing physical activity, whether they can start up again. The problem is such survey is costly and unnecessary to collect frequently because it imposes burden on users and the reward is actually changing slowly. So the hard steps team suggests to collect the survey every week. This is why we have sparsely observed rewards in our algorithm. Now, the challenge is that it's difficult to update the policy efficiently, because if we view the weekly reward as a cumulative effect of all the actions in this week, then the state space is very large. So we propose to use causal information to speed up learning. The causal information can be represented by a causal directed acyclic graph, and such DAG encodes domain knowledge. This is the DAG provided by our domain scientists. The S is the current context. For example, it can be the prior 30-minute step count, the current temperature and location. The action A is whether we should send a notification or not. The proximal outcome M is the 30-minute step count. And the reward in the algorithm is commitment to physical activity. E is the engagement. For example, we can use app page view times as a signal to represent whether a user is engaged with the app or not. And since the rewards are sometimes missing, for example, if we only observe a reward at the end of the week, then 6 out of 7 rewards are missing. So we propose to use another indicator O as an emission of R. For example, it can be bouts of unprompted physical activity. If a user remembers to stand up and take a 10-minute walk frequently, then we know that the user is committed to physical activity. So that's why we can use such signal to help us, to give us some information about the missing rewards. Here in this stack, the proximal outcome M and the engagement E are mediators of the reward. We expect the positive effect of action to go through the proximal outcome and expect the negative effect to go through the engagement E. So that's how we incorporate the delayed effects of disengagement into this problem. The domain knowledge provided by the scientists is encoded in the DAG. Specifically, the mediator M and the emission O will help us to speed up learning. In the RL algorithm, to be robust to the assumptions in the DAG, we only partially trust the DAG when making decisions. A model-free algorithm will be used to update the intervention policy, and the DAG is only used to construct the prior and impute missing rewards. Let me first introduce the components of RL in this project. Let's briefly assume that the rewards are observed for now, but it will be imputed later. Notice that 5 actions jointly affect 1 reward, and this reward for the day is observed at the end of the day. So we fit the problem into the framework of periodic Markov decision process. In a periodic MDP, we allow non-stationarity within a period. For example, in this project, each day can be viewed as a period with 5 decision times. And in order to make the state transition Markovian, we will construct the rewards in the following way. At the first decision time, the state vector is the previous reward, previous engagement, and the current context. And similarly, at each of the following decision points, the previous mediators are added to the state vector. So in this way, given the current state vector, the reward is independent of the history. So by utilizing the DAG and construct the state in this way, we actually form a Markov decision process. Our algorithm is based on randomized least squares value iteration. So the Q function is the cumulative reward given the current state and action. And the maximal Q function is the optimal Q function is the maximum one over all the possible policies. RLSVI put a linear model for this Q function. Assume that it is linear in a basis function phi. And RLSVI take actions with respect to the posterior distribution of this optimal Q function. In this way, we only explore statistically plausible Q functions, and this is an efficient way of exploration-exploitation trade-off. We have 2 technical challenges. The first one is that the state and the reward contains unobserved rewards, so we will impute unobserved rewards online. The second one is that to encode the domain knowledge, we construct the prior based on the DAG. However, the posterior distribution of the parameters of the Q function becomes intractable in this case. So that's why we propose to use bootstrap Thompson sampling to deal with the intractable posterior distribution. Remember that the posterior distribution is a combination of prior and observed data. If we use the prior to generate some artificial data and use the artificial data to substitute the prior, we can actually combine the artificial data with the observed data to obtain a draw from the posterior distribution. So that's how we approximately sample from the posterior distribution. I'll first go through the framework briefly, and then we can dive into the details. At each day D, we first generate some artificial episodes and combine it with the observed episode. And then we impute the unobserved rewards. This step is model-based. And then in the next step, we sample the parameter of the Q function from the posterior distribution with bootstrap Thompson sampling. This step is model-free. Then we take the greedy action with respect to the draw from the posterior distribution and observe the proximal outcome. Finally, at the end of the day, we can observe the engagement, reward, and emission O. Specifically, to impute the unobserved rewards, a challenge in sequential decision problem is that previous prediction error may be propagated to future decisions. So that's why we need to re-impute all the unobserved rewards every day. In Bayesian statistic, the unknown parameters and unobserved rewards can be treated equivalently. So we aim to find the joint maximum a posteriori estimate of the unknown parameter and the unobserved reward. Again, this posterior distribution is intractable, so we can actually use the combined data set to find a maximum likelihood estimator for unobserved data and unknown parameter. Then we ignore the parameters and get an estimate of the unobserved rewards. To draw from the posterior distribution, we use Bayesian linear regression. Specifically, in this Bayesian linear regression, the predictor X is the basis function phi, and the response Y is the estimated optimal Q function. It assumes that all the future actions from this decision point are optimal, and then try to find what is the best option for this current time point. So Y is defined as the estimated optimal Q function if we are not at the last decision time. But if we are at the last decision time, a reward is observed, so we add RT to the response Y. Finally, we use weighted linear regression with Bayesian bootstrap to find the draw from the posterior distribution. We constructed testbed using the previous data from HeartSteps V2. So in this way, we can use the testbed to generate data online and see what the cumulative reward is if we use the online algorithm to update the policy. Well, we compare 4 different algorithms. The first one is the proposed algorithm. The second one is finite horizon RL, which only updates at the end of the week. The third one is Thompson sampling that maximizes the proximal outcome. So this is the method used in previous implementations. And the fourth one is the random policy. We construct 4 different tests, 4 different variants of the testbed to represent potential possible environments in the next implementation. We can see that in all these implementations, our proposed algorithm can outperform the baseline methods. So to summarize, in this new implementation, we use an RL reward that is closer to the true health reward, the maintenance of physical activity. We propose to harness causality to speed up learning when the rewards are sparsely observed. Specifically, causality is used to reduce the state space, to construct the prior, and to impute the unobserved rewards. And this clinical trial is expected to go into the field next summer. Okay, that's all of my talk. Thank you.
All right, thanks. I was paused for a second. Thanks so much, Daiqi. Again, we'll move on to the next speaker, but if you have any questions, you can put them in the Q&A. Our final speaker in this session will be Wenbo Fei. Wenbo is a PhD candidate in the Department of Biostatistics at Columbia University. She works with her advisor, Dr. Yuanjia Wang, to develop statistical methods that facilitate precision medicine by leveraging evidence from multiple data sources. So I'll hand it over to you.
Can you see my screen now?
Yes, we can.
Thank you for Marissa's introduction. Hi, everyone. Thank you for coming to my presentation. Today, I'm going to talk about machine learning methods for optimal early decision treatment rules with multi-domain intermediate outcomes. Here is an overview of today's presentation. I will start with the introduction and background of our study. So precision medicine is an innovative approach to tailoring medical care and treatment plans that takes into account individual characteristics, such as genes, environmental risk factors, lifestyles, and behavioral factors. It is a broad paradigm that involves the use of advanced statistical methods and techniques to analyze complex data to achieve multiple objectives. And here is an example framework for advancing precision medicine in clinical trials for mental disorders. From the side panel, we can see that it involves collecting and processing multi-domain outcomes to get an accurate measure of the intervention's effectiveness and individual patterns of change, so as to design individualized treatment rules that patients can benefit more robustly from the treatment course. The implementation of precision medicine in mental disorder is challenging due to disease complexity and the heterogeneity of treatment response. For example, the diagnosis often relies on patients' subjective experience, and the treatment response are influenced by several factors, such as placebo effect, diagnostic criteria, personal preference. Therefore, less than 50% of MDD patients will achieve remission after a first-line treatment. In the meantime, studies also show that interim measure of disease improvement often can predict the longer-term outcomes during follow-up period in clinical trials. Here is an example of symptoms of depression disorders in the Diagnostic and Statistical Manual of Mental Disorder written by the American Psychiatry Association. We know that depression is a clinically heterogeneous disorder, and it contains three key domains. The emotional domain usually describes symptoms such as sadness, anxiety, suicidal ideation, etc. And the cognitive domain usually include attention, concentration, memory, judgment. And also a physical domain, it includes symptoms such as fatigue, eating or weight change, insomnia. So these symptoms can be evaluated through item responses such as HAM-D score or biological measures such as fMRI or EEG. Current individualized treatment rules learning framework for mental disorder usually requires a summary scalar outcome as the response. For example, we can use the sum of the observed HAM-D items. And in psychiatry and psychology, people more often utilize a low-dimensional latent variables to capture major component of patient's mental status. For example, Chen shows that learning ITR through latent mental states can provide a more accurate assessment of mental disorders. In the meantime, the importance to treatment response of latent domains differs in individuals, and these need to be taken into account when constructing a more informative summary outcome. For example, some patients are more eager to solve somatic symptoms such as insomnia. Others may benefit more from psychotherapies to improve the emotional symptoms. And to address this issue, researchers propose a weighted linear form of composite outcomes to integrate patient's preference when learning ITR. And motivated by the above work and pre-mentioned challenges, we propose an ITR learning framework that can derive a personalized composite outcome used as the reward, which can integrate intermediate outcome from multiple domains through the latent state model, and then use a personalized weight to address the heterogeneity of patients' response. And this composite outcome provide informative measures on the latent mental states and facilitate early detection of no responders and early intervention. In next section, I will give more details. This figure shows the graphical structure of latent domain Z, observed intermediate outcome Y, and final outcome R. Well, on the left hand, the Y0 and Z0 are the pre-treatment outcomes, while Y1 and Z1 are post-treatment outcomes. Here, Y could be the observed outcomes, such as HAM-D score, which are ordinal, or related EEG measure, which is continuous. And Z represent the latent domains, such as psychological, physical, cognitive functions, as we discussed before. X and U are baseline covariate for tailoring treatment and personalized weights. And GZ is the composite intermediate outcome we derived, and it is linked to the observed long-term final outcomes. Specifically, we assume the composite outcome G as a personalized aggregation of multiple latent domains shown in Formula 1, where omega is a vector of weights, and we assume it follows a Dirichlet distribution. And this standardized G is linked to the long-term final outcomes. Furthermore, for reliable instruments, we assume that the first two assumptions are standard. We've assumed the conditional independence and invariance assumption. And these two assumptions are standard in factor analysis and item response theory, as discussed in the previous literature. And the third assumption ensures that the optimal ITR under the composite outcome is rational. Additionally, we also assume the standard stable unit treatment value assumption. And this implies that potential outcomes for each individual are unrelated to the treatment status of other individuals. To infer the unobserved latent mental state Z, we can use a flexible, unsupervised feature learner modified from the Boltzmann machine model to model the joint distribution of observed items Y through a set of binary latent variables Z. Specifically, for ordinal Y, we assume the ordinal RBM model. And for continuous Y, we assume the Gaussian RBM model. Under the above model and assumptions, we can obtain the joint likelihood shown in the Formula 2. Note that the integral over omega can be computed analytically, and the integral over Z in the likelihood can be replaced by the summation of the joint likelihood over all possible values of Z. Since the dimension of Z is low, this is computationally efficient. Therefore, we obtain the joint likelihood in the Formula 3, while Ri represents the normalized success probability of the binary variable R. By using both pre- and post-treatment data to estimate the shared parameter, we can improve the efficiency. To ensure the robustness, we use the composite likelihood approach to obtain a quasi-MLE for the parameters by minimizing the following negative log likelihood. And the latent state can be inferred by its conditional expectation. And the personalized weight can be estimated by plug-in MLE estimator. Therefore, the intermediate composite outcomes is estimated by the inner product of omega hat and Z hat. After obtaining the intermediate composite outcome, our treatment recommendation would be the one with higher expectation of personalized reward. We can incorporate the augmented outcome weighted learning structure to estimate the individualized treatment rule as shown here. Well, phi is the large margin loss, tilde R is the surrogate outcome, and pi is the treatment assignment probability in the clinical trial or the propensity scores in an observational study. In the next section, I will show some experimental results. For the simulation study, we will compare the standard methods with ITR are learned based on observed outcomes directly, and with latent methods, where we consider each domain has equal weight, as well as the gold standard methods, which represent the best performance ideal case that all parameters and underlying distribution are known and correctly estimated. For the evaluation metric, we compared the interim treatment accuracy, interim personalized reward, long-term treatment accuracy, and long-term response rate. This figure shows the simulation result of short and long-term outcomes evaluated on the test dataset with 1,000 replications. The proposed methods perform significantly better than the alternative standard methods in all metrics. The mean value in all scenarios increase, and the variance decreases as the sample size increase, except for the standard methods, which has almost constant variance. We can also note that as the sample size increase, the difference between the proposed methods with the gold standard methods decreases, suggesting that the proposed estimation methods is consistent. We also apply the proposed model to the EMBARK study. EMBARK study is a randomized clinical trial study on the major depression disorder, where participants with early onset recurrent MDD were randomized to an 8-week course of an antidepressant in the SSRI class or placebo. In our study, we consider Y0 as the HAM-D score at week 0, Y1 as the HAM-D score at week 4, and the responders is the CGI score at week 8. We also include some EEG and fMRI features as continuous way to assist learning of the latent mental domains. Gender, age, race, and education year are used to construct the personalized weight. To understand how latent domains capture the patient's mental states, we visualize the fitted weight matrix. The first latent domain represents a general psychology factor that negatively affects various psychological symptoms, including depressed mood, suicide, work interest, and guilt feeling. The second latent domain represents somatic symptoms such as insomnia. And the third latent domain is specific to biomarkers with a strong negative relationship with the first PC of EEG measure. These three latent domains capture the main construct of mental health, measured by psychological, physical symptoms, and cognitive processing factors. And this figure shows the heat map of tailoring variables in learning ITRs and 8 baseline subgroups stratified by the estimated optimal treatment for all subjects. Overall, 90% of patients are recommended a placebo instead of an antidepressant under the estimated rules. This may indicate that a subgroup of patients may not respond to antidepressant, thus reducing the burden of non-effective treatment. SSRI is recommended to older patients or females with higher neuroautism scores and lower cognitive control scores, which is consistent with previous findings. Since the study includes patients with MDD, most subjects have poor baseline mental states in at least one domain. Optimal treatment assignment patterns are strongly associated with identified baseline latent domain. For example, 97% of subjects in subtype with poor state across all mental domains are recommended to antidepressant, while in contrast, only 70% of subtypes 101 and 100, which has a good somatic state, are recommended to take the SSRI. This table shows the analysis results of the value function under fitted ITRs evaluated on various outcome measures on the test set. Our methods performs the best under all evaluation metrics based on the non-term final outcomes, because the aggregation function G nurses the personalized weight relative mental states to the final CGI outcomes. Overall, our methods achieve a median response rate of 0.49 compared to 0.46 for the standard methods. Moreover, it also yields a higher response rate than the universal rules of assigning all subjects to the SSRI. We can also know that our method yields a lower value of the non-term HAM-D score than the standard methods, even though it does not directly attempt to minimize the sum of the total HAM-D score, nor did it use the HAM-D score in the predictors. The proposed method yields a higher interim HAM-D score than the standard methods because the latter one is designed to optimize this measure. But we can see that the proposed methods also yield a highest early detection rate of non-responders and responders. Finally, to summarize this presentation, we propose a new methods for learning the optimal ITRs, which can learn latent mental states from intermediate outcomes of various domains, as well as individualized aggregation functions to provide as a priori indicator of long-term treatment outcomes. And through experiments, we show that the proposed methods can effectively reduce observed items into lower dimensional representations with interpretability. And it integrates biological, psychological, and demographic factors into a personalized treatment outcomes. Therefore, to provide informative treatment recommendations through the interim outcomes. And the future work for our project is to extend our methods to provide the optimal ITRs for any function of the latent representations. For example, we can construct domain-specific treatment rules by targeting a particular mental domain, or develop the inactive personalized weights to control for side effects. And the proposed framework can also adapt to multi-treatment and multi-phase recommendation rules. And moreover, we can integrate pre-treatment data from large-scale observational study. And this will increase the efficiency of the learning of the latent mental domains. That's all for today's presentation. Here are some relative reference, and thank you for listening.
Great. Thank you so much, Wenbo. That was great. It looks like we are just about at time. We have less than a minute left in our session. So I'll just thank all three of our speakers again for talking about your wonderful precision medicine methods.
Thank you.
Thank you all.